Welcome back, everyone. For the next hour and a half, we are going to look forward and examine the lessons to be learned for healthcare policy and how to implement them in the months and years ahead. Don't forget, your questions are at the heart of our discussion a little bit later on, so please do use the Q&A button on your screen and submit your questions and indicate who you would like to answer them. So let's kick off. Our second session is a man who leads the largest healthcare provider and employer in New York State, caring for more than 2 million people through 23 hospitals and over 800 outpatients facilities. He's Michael Dowling. He's originally from County Limerick, and he is CEO of Northwell Health. And he's one of healthcare's most influential voices. He leads a clinical, academic and research enterprise with a workforce of more than 75,000 and an annual revenue of $14 billion. Last year, he led Northwell through the first COVID-19 epicenter in the United States, and he has been providing great words of advice for the world in the months since. Over to you, Michael.
Thank you very much. Delighted to have the opportunity. First of all, let me congratulate our RCSI for holding this meeting and for giving me the opportunity to say a few words for a few minutes. I will be relatively brief since I know that you stick to the time pretty tightly here. So let me start by stating the obvious, and that is that 2020 has been an unbelievably transformative year for all of us in healthcare. It has tested us. And I think overall, despite some criticisms and Monday morning quarterbacking, which goes on all the time subsequent to a crisis, we did relatively well. At Northwell, we've actually seen over 200,000 COVID patients. And back a year ago, at the height of the crisis, we had about 3,500 patients on a daily basis in our hospitals. But there have been many lessons, and we've written about those in the book that we wrote. But we saw, for example, during the crisis, we saw that the benefits of integrated health systems, and I'm going to come back to that point. We also saw the fact that during a crisis, there is an amazing ability to be innovative and to be creative, and that it blossoms and flourishes in a crisis. And we also, of course, observe the importance of the frontline staff and everything that we should be doing to enhance their satisfaction, their engagement, and their morale. So I could talk about all of these issues for a long time, but let me just conclude this little comment by saying that I believe very strongly that we will all be better because we went through a crisis like the past year. Difficult, yes, but I think as individuals, it has forever changed us. It has changed our perspective. And I believe as organizations, it has changed us as well. I think we will overall be better for the fact that we went through this issue. And I think healthcare will be better in the future if we keep our eyes on the proper focus. I'm actually also very optimistic about the future. I think that there are lots of learnings where we can continually improve. So let me get to the point that you asked me to speak about, which was learnings for the acute hospital. And so here's where I just want to focus a little bit on a couple of central points. One is that I think it is not appropriate, if you're a policymaker or an operator, to look at the acute care hospital in isolation. I don't think you can. We don't do it here in our health system. And I think as we look to the future, dealing with the acute care hospital in isolation is a huge mistake. Because the way I look at it, an acute care hospital is one cog in the chain of healthcare delivery. Healthcare delivery is a continuum. I will come back to that point in a little bit of detail. But the hospital is only one cog in that continuum. And the role of the hospital has been changing over the years, definitely changing over here. And I believe it will continue to change. Just give you a couple of examples. More and more care is now, that was once delivered inside a hospital, is now going to be delivered and is being delivered outside the hospital. The traditional model of the acute care hospital as the central hub, I think, is mistaken. I don't think that might have worked in the past, but I don't think it works today. And I don't think it works in the future. And it was very, very evident also during the COVID crisis. More and more care is moving outside the hospital. We, for example, have about 800, and on the number you have on the screen is a little old, about 850 outpatient facilities. So much of our surgery is outpatient, most cancer is outpatient, imaging, most of it is outpatient, et cetera, et cetera. And also, given now the fact that the telemedicine digital part of the world of healthcare delivery will dramatically accelerate, that also takes more care out of the hospital. So then what is the hospital? Well, the hospital in the future, in my view, is evolving into being basically intensive care. Highly specialized, high-tech, high acuity, critical care. That's what's going to be primarily in your hospitals in the future, and that's what we should be planning for. That's how we should be looking at them. That everything else that should not be in the hospital should not be in the hospital. And in many, many places, there are things going into the hospital which shouldn't be there, which causes massive overcrowding, inappropriateness, etc. And of course, also hospitals will deliver babies for the most part, but it will be, especially your large acute care hospitals, will be specialized. So the goal then, in that kind of a situation, is how to provide the best care for high-risk patients using the best human competence and the best use of technology. Now, if you look at, stand back from it for a second and let me raise a couple of questions that we have to ask ourselves. And all of these to me are opportunities for the following. This is what, if you're an operator or policymaker, these are the kinds of questions. I'm not going to list all the questions, but the kind of questions that you should be looking for and looking at. One is how to create and operationalize an integrated system of care. And you'll see on the slide here, where all of these parts of the delivery system have to be interconnected, seamlessly interconnected, part of basic systems of care, not isolated, not in silos, all working together. We have all of those elements in our health system today, inside Northwell. And as you can see, the hospital is one piece. In our health system, for example, only 50% of my $14 billion budget today is hospital care. The rest of it is all of those other pieces. And that's what we have to be delivering. So you can only look at the role of the hospital in the context of the totality here. And therefore, that's why I believe you should not look at the hospital care piece, the acute care hospital care piece, in isolation. So that's the first question, how to create and operationalize an integrated system of care like this. And that's what should be done in Ireland. And that's what's being done in many parts of Ireland and being done elsewhere around the world. Not easy work, tough work, but you have to have all of the pieces working seamlessly, because the patient rotates across over the course of a lifetime across the various components of this map that you see in front of you. The second question that I think we have to ask ourselves, and it relates to each piece, including the hospital, and that is how to control the growth of stifling bureaucracy so that innovation can flourish. We demonstrated remarkable creativity during COVID here because a lot of the regulations by government were relaxed. And many of those regulations should never again be put back in place because they were unnecessary, inappropriate, and were stifling to creativity. So that's going to be a big challenge, especially for government-run healthcare systems, or governmentally systems that have major oversight by government, where you load on a whole bunch of regulatory issues and compliance issues, which are the antithesis of creativity. And what you need going forward is more and more creativity and innovation, not less. A couple of other questions. How to become customer obsessed? It's all about the customer, not just about the provider. How to invest going forward in talent management and succession planning. And given the nature of work that we're now dealing with, which was mentioned by the previous speaker, how do we train employees, both in the medical school, nursing school, administrative side of the world? How do we train them differently for the world that we're going into? Not the world that we're in, but now the new world that we're going into, including the world of digital health. Another question, how to promote the interdisciplinary provision of care so that all disciplines work in unison and together. That happened during COVID. We actually excelled at it at the height of COVID, despite the difficulty. But there is a real danger that despite that we did it during COVID, that we now go back to the old way into some clinical silos, which we should avoid. And as I mentioned, how to adapt to the changing nature of work. More remote work, etc., and how you maintain culture in an organization when more things are remote. And the other thing is how to promote trust in and investment in science and technology and research. During COVID, over in the United States, there was a neglect of science and scientific advice, and that was a real mistake. And I think that the more scientific research that we do, the more academics we do, the better off we will be in the future. So what I would say to conclude, and I'm watching the time here, is that and my plea would be that don't look at the acute care hospital in isolation. I think if you do that, we're making a huge mistake. But you've got to operationalize it so that it's only a piece of the delivery system. And then how you actually effectively over time move out of the hospital those things that we all know should not be in the hospital anymore. If we move things out of the hospital that shouldn't be there, you will help redefine what the hospital is. And it's the only way you will get to the point of having the hospital do what the hospital should do, and then have all of the other pieces do what they do. And if you do that, I think you will move forward towards creating an integrated health system and redefine the nature of the acute care hospital. We manage COVID because we're all the pieces. If we only manage COVID through the lens of the hospital alone, we would have been in a disaster situation. And that's another lesson of COVID. It demonstrated the benefit of integrated systems, the role of the hospital, but also the role of all of the other pieces working in collaboration with the hospital. So that would be my plea. That would be my suggestion. It's hard work, but it basically requires throwing out a lot of the rules that currently exist in many places and writing a new set of rules. So with that, I wish you all the best. I thank you for the opportunity to say a few words. And of course, a discussion like this would take hours and would be delighted to participate in that. But I know that you guys are pretty tough with the time schedule here. And I think I have about 5 seconds left. And therefore, before you cut me off, Audrey, I'm going to say thank you for the opportunity.
Michael, it's been our pleasure completely. We could listen to you all day. Thank you so much indeed for your insights. You make it sound very, very easy. And we know it's not.
Basically, you know, it depends on how you look at it. If you look at it and you promote simplicity, it becomes simple. People look at it and make things complex. The hardest thing is to make complex simple. It's very easy to make the simple complex. Go the other way.
That's very true. Michael, great to see you. And thank you very much indeed for joining us today. Michael Dowling joining us there from New York. Well, our next speaker this afternoon is Jessica Martinez, Senior Program Officer in the Global Health Strategy and Portfolio Management Organization in the Bill and Melinda Gates Foundation. She drives strategic engagement with global pharma and biotech partners on innovation and sustainable financing. In relation to COVID-19, Jessica has convened multi-party vaccine development alliances, and before joining the Gates Foundation, she was a senior member of Pfizer's corporate strategy team. Jessica.
Thank you and good afternoon, Audrey. Thanks for having me. I appreciate that RCSI is having this very important event. And I also appreciate the opportunity to speak with you. Thank you for the lovely introduction. As Audrey mentioned, I do lead our life science engagements, and I have been recently very focused on COVID, and that's actually why I'm here today. I'm here to talk to you about the impact of COVID on global health. And so you might wonder why I want to talk to you, a bunch of HEOR practitioners and health system leaders and policymakers sitting in a high-income country or a number of high-income countries, predominantly located in the global north, about the lessons from COVID and our efforts to lessen the burden of disease for people in low and low middle income countries. And admittedly, I will say, when I first agreed to do this last fall, it seemed like this was going to be a highly theoretical conversation. However, as it turns out, that hasn't been the case. So let's discuss. I like to level set before any discussion, and where possible, I like to call out what's going well. So to me, COVID is, among many things, collaborations 20 years in the making. And now, what do I mean by this? Well, this has been a time of unprecedented scientific collaborations. There have been 500,000 genomic sequences shared online, and in the span of a mere 10 months, we went from a concept for a vaccine to an actual vaccine in people's arms. And this has also been a time of unprecedented development in manufacturing collaborations. Oxford and AstraZeneca, Pfizer and BioNTech, Novartis and Sanofi making the Pfizer-BioNTech vaccine, Merck making J&J's vaccine, Serum Institute of India making everyone's vaccine, including AZ's and Novavax, GSK and CureVac, etc. However, these wins also highlight some pretty glaring gaps and deficiencies. For example, we need significantly more investment in surveillance, therapeutics, delivery, and deployment. So looking ahead, I believe we can take lessons from COVID to not only help us end this pandemic more quickly, but to also prepare for the next one and accelerate everyday progress on global health. Now, to be sure, people will be discussing and writing dissertations about the lessons from COVID for years to come. And we're only a year in. So this is not meant to be an exhaustive or even a comprehensive lesson, or list of lessons, I should say. Rather, I want to focus on 4 very tangible, already very clear lessons that are specific to this group and to the global health effort. So the first lesson is the importance of new technology platforms like mRNA technologies, structure-guided immunogen protein design, and small molecule adjuvants. Take, for example, the promise of mRNA technologies, and let's actually follow that through. Like many of the platforms that I just mentioned, the idea and the promise of mRNA technologies has been around for a while, but it hadn't broken through. Why? Well, COVID certainly turbocharged it, and today, mRNA vaccines are expensive to manufacture and deliver. But with more innovation and greater global adoption, these chemistry-based platforms, like the mRNA vaccines and therapeutics, could actually be key to defeating significant public health threats tomorrow. Why? Because we already know that mRNA platforms can be used to help solve not just other infectious disease challenges, but also genetic diseases and cancer. And so imagine what a global network of local mRNA technology-enabled players could actually do for global health. Well, first and foremost, this type of platform really levels the playing field for developing country manufacturers, because chemistry platforms require significantly less investment than the biologic platforms necessary for most novel vaccines and therapeutics today. These would help the vaccine and medicine developers in emerging countries that are currently left behind actually leapfrog the biologic platform divide that's kept them from engaging more meaningfully in global health efforts, and bring them all up to speed in one fell swoop. And not only would this help them with actually bringing them up to speed, but this would also help solve the cost and development challenges, or rather the cost and delivery challenges, by localizing manufacturing and distribution in emerging countries where these life-saving innovations are needed the most. Similar arguments can be made for the other technology platforms that I noted above. Structure-guided immunogen protein design can streamline development of more traditional subunit vaccines to help cut the cost and the time needed for development. Small molecule adjuvants can help alleviate the rate-limiting effect of limited stocks of natural adjuvants like squalene, giving players that don't have the purchasing power or the relationship with the current adjuvant players and companies a leg up. Okay, lesson number 2. We still need more expansive and innovative approaches to funding and financing. We need a higher risk tolerance and more aggressive investment in basic R&D. That's what's actually generated the aforementioned platforms. Lackluster funding and risk aversion is actually part of the reason, and some would say the majority of the reason, for why these technologies didn't break through until now. We need ambitious goals and long horizons. And these long horizons require multi-year commitments, not just from the traditional funders, but also from non-traditional funders. So while it's great to have governments and multilateral players and global funders like the foundation putting money into these efforts, we also need private sector investors, because these are the ones that bridge the gap from short-term investments to long-term investments. And we need to open up more avenues for these investments to reach local vaccines and therapeutics companies, particularly in developing countries. With COVID, traditional funders were actually forced to prioritize multinational players over local players because they had the best chance of bringing vaccines and therapeutics forward most quickly. But this actually created a double whammy for these developing countries. Not only were their local players left behind in terms of investments, but now they're also having to compete with EM&C home markets for products, and we've seen how that's going. I also want to point out that investment can take many forms. Yes, direct financial assistance is what comes to mind first, but other forms of investment, including in-kind contributions, are just as valuable. And by these, I mean things like technology transfers, technical assistance, and shoring up of supplies and ensuring equal access to raw materials, API, packaging, etc. Lesson number 3, and I'm going to caveat this one a bit by saying that just about all of our global health infrastructure and capacity could do with improvement, and COVID has certainly brought that to the fore. And I'm not necessarily saying that regulatory is especially bad, but of all the bottlenecks that COVID has identified for us, regulatory is a relatively low-hanging fruit, especially for this group. So lesson number 3 is that we can make regulatory better with comparatively less effort than a lot of the other bottlenecks. I mean, regulators did an excellent job of balancing speed with safety for COVID vaccines. There are no fundamental reasons why we can't keep that level of speed that we've achieved with COVID vaccines going forward for other vaccines. So does that mean that we truly believe that a new TB vaccine really will take 8 to 9 years? I'd like to challenge that. Surely we can do better. But as impressive as the regulatory efforts have been for the COVID vaccine, they've fallen short for therapeutics. And again, there are no fundamental reasons why we can't apply the same principles that were applied to speed vaccine regulatory efforts to therapeutics. So what does good look like? Well, surely we have to make sure that the right resources are in place to bolster the capacity. This is a given, and there are already efforts underway. So I would ask for support for regulatory harmonization efforts wherever possible. But we also need to allow more streamlined submissions and better data sharing across agencies. Why don't more NRAs, National Regulatory Agencies, accept stringent regulatory authority packages? And why does the FDA embargo and withhold their submissions instead of sharing them, even after they've reviewed them? We also need to develop new methodologies that enable speed without sacrificing safety. And this is where a lot of your work can come in. Establishing things like robust correlates of protection is a given and is highly necessary, but also highly doable. And so these methodologies and creating these methodologies will require buy-ins from academics and developers and regulators and the end users, but it is doable. Which brings me to lesson number 4. And this is the most important one, because none of these preceding lessons should or even can happen without accounting for health equity from the start. And when I say health equity, people say, well, yeah, it's the right and the moral thing to do, but I want to make the argument that it's also the smart thing to do, because controlling global spread early limits opportunities for mutation, which is what makes this conversation much more concrete rather than the amorphous one that I thought we would be having last fall. The only path to a sustainable global solution to any health challenge, whether it's a pandemic or even just normal run-of-the-mill flu, is health equity, because national security equals health security, which equals global security, social, economic, and even military. These are all inextricably linked, and public health is global health. And global health can't and won't be, and the global north can't and won't be safe until the global south is. In fact, just to scare you a little bit, today, 2/3 of countries don't have the resources or the preparation needed to respond to pandemics, outbreaks, or other health emergencies. That's pretty unacceptable. What else is unacceptable is that no major pharma companies are involved in R&D for 10 of the 16 classes of emerging infectious diseases that we're all keeping an eye out for. And so I say this realizing that it sounds like an insurmountable effort. So where do we even begin? Well, any global health response effort must start with accelerating, intensifying, and sustaining innovation to fight everyday global health challenges. If countries and agencies are busy fighting TB, malaria, neglected tropical diseases, non-communicable diseases, vaccine-preventable diseases, they're not shoring up resources to actually help solve for pandemic preparedness when those pandemics strike. And I think what we've learned from COVID is you can't do both. Which brings me back to where we started, collaborations. And the fact that my ulterior motive in being here is actually to recruit you and enlist you to help in this global health effort. The COVID jumpstart was enabled by data and knowledge sharing right from the start. Remember when I mentioned those 500,000 shared viral gene sequences? Why is this? Because data and knowledge are universal languages. Trusted, robust data is the best tool we have to enable the collaborations, both traditional and non-traditional, needed to bring together the people, technology, money, and infrastructure necessary to mobilize the global health community, whether it's to respond to a pandemic or even to address everyday global challenges. Now, there are a lot of glib adages about never wasting a good crisis, and there's even a debunked one that claims that in Chinese, crisis means dangerous opportunity. But I think that in this case, the COVID crisis really does provide us with an opportunity to challenge our assumptions, an opportunity to demonstrate what's possible when we do that, and to remind us that we're all interconnected. So what are we going to do with this dangerous opportunity? Well, first and foremost, we need to carry those 4 lessons forward. We need to develop new, robust fact bases, not just for the sake of data. And I say this realizing that I'm speaking to a room full of HEOR experts, but rather because data and numbers are that universal language. And we need this universal language to foster these collaborations, which brings me to the plea I would like to make to this group. I'm not an HEOR expert. In fact, I know enough about HEOR to know that I should leave HEOR to the experts. But I do know this. You guys are the ones generating data and creating fact bases. Your research lends credibility to the new technologies I discussed. Your data supports deployment of these new forms of investment and capital that I mentioned are needed. Your studies support the foundation of the regulatory submissions that should be shared across organizations. And your analyses help us to assess the impact of our efforts towards health equity. How do I know this? Firsthand. I am building my own fact base to try to enable multi-stakeholder conversations. It starts with DALYs to quantify the burden of disease and ends with QALYs to assess the impact of any efforts. I'd love your help in strengthening this, and I really hope that I can count on it going forward. So please, challenge yourselves to expand your circles. Find new partners for your studies, new audiences for your data. Strengthen your existing collaborations, and also explore collaborations with partners you've never considered in the past. As part of my ecosystem remit, I often say this, which I think resonates even more strongly today. Global health challenges are multifaceted and multifactorial. If any one stakeholder could solve them, they would have been solved already. We need bold new collaborations to tackle these challenges, so please help us. Help us generate the data that'll bring stakeholders to the table. Help us measure the magnitude of our challenges and the impact towards solving them, and help us make the case for bringing these 4 lessons forward. The importance of new technologies and investments, the need for streamlined and faster approvals, and the need for interconnectivity of our global health systems, and the need for health equity. So thank you for your time and consideration. who knows, maybe we'll have a chance to collaborate in the future, and I truly do hope so.
Jessica, thank you so much indeed for that vitally important contribution to our discussion this afternoon, Jessica Martinez. Now, our final speaker for this session is a man well known to you all. In the past year, so much has been asked of the organisation that he leads, the incredible staff of our hospitals, our GP practices, our clinics, our long-term residential centres, hundreds of thousands of people. Will you please welcome the Chief Executive of the HSE, Paul Reid.
Thanks, Audrey, and I hope you can hear and see me okay.
Yeah.
Thanks, Audrey, and good afternoon. And I'd like to thank the RCSI, who have been great partners for us, not just throughout the pandemic, but in great support of the HSE in delivering innovation in health systems. So thanks to Professor Colin Kelly and his team. I just really, Audrey, want to make 5 brief reflections back on COVID over the past year or so in terms of impacts on the health system. And then 5 kind of look forward pieces about how I think we can take those learnings and build a very different future for the health service in Ireland. And so I guess, first of all, just the broad reflections looking back. And the first one I would set out would be from our perspective. And something David just touched on in his presentation. For me, it was how we needed to operate at pace and implement change and innovation at a speed at which we never implemented it before. And it's one of the great positives I take from our response that we did operate at that pace. And it's also how we managed, and David had this in his presentation, to give direction from the centre, but let the services go. So it's kind of a tight and loose approach, I would describe it as, where we gave direction, but let the services go at pace. And I think there's a great learning for us. And one of the feedbacks that I certainly gave through government and cabinet committees and opposition parties and leaders and everything at that time was that we were going to operate at a pace that we would most likely get 70% of our decisions right and most likely 30% of them wrong, or certainly we would do different. And I think that has to be the environment in which we are allowed to operate. It's difficult in the health system, but it has to be when you're operating in a pandemic to make the decisions quick. And I'm quite proud of how we took that approach and took that response. And yes, you take it on the chin when one of those decisions go wrong, but it's much better having 7 of them right at every given time. So I think that was a big learning for us and something I want to sustain us through into the next phase. The second kind of reflection I would put was for us to try to understand how during this period, and we've tracked it, that we gained public trust and confidence in a much stronger way than we had heretofore. And we have tracked it and we can demonstrate it that public trust and confidence in the health system did continuously grow during the pandemic. And there's a couple of reasons probably underlying some of that research we can draw out. One is certainly, I think when the public were scared, and we were all scared at a time back last March and April, they put their trust in the health system probably like they've never done before. Secondly, I think what the public heard was a much stronger and unified voice from the health system, a more coherent voice. And they didn't hear possibly what we had experienced, and certainly when I joined the health service, just less than 2 years ago, a very fragmented set of voices coming from the health system, whether it's consultants, complaining about the HSE or having a pop off the HSE, or GPs arguing against the HSE, or we're arguing against government, or government arguing against ourselves. I think they heard a much coherent voice, and that gave the public confidence and trust at a time they really needed it. So I think there's a big reflection and learning that I want to make sure we learn from that period about how we work in a more collaborative way with our stakeholders. The third one relates to, which again Michael had a lot of in the presentation, and I've met Michael before when I joined HSE, I purposely went out of my way. A lot of great respect for Michael and what he's achieved with Northwell and many other health systems. But it's really about this whole issue about community care, primary care. And one of the early innovations or processes we had to put in place was to invest strongly in our community system to relieve the pressure on our acute system during a pandemic. And we've been talking about this for many years, and Sláinte Care is the strategy, and it's the right strategy, but it hadn't been put into practice. And I do believe that we put more of Sláinte Care in practice in the last year than we possibly did or would have done in the next 3 to 5 years. And that whole set of new ways of delivering healthcare had to be done at pace, and we've seen the benefits for it. So we've seen working with our GPs in a whole new way. We've seen our National Ambulance Service provide a whole new set of services beyond just being a 24-hour response paramedic teams, providing help to people at home, providing vaccination centres, providing test centres, providing integrated care between acute and community. So there was a whole set of investments we had to put in place around home care, keeping people at home and well at home, and also addressing some of the most vulnerable, the homeless community during COVID. So I think that was a really strong set of processes and new health pathways that we put in place during COVID that we have to significantly learn from. And the fourth area, I think, has to be a very strong reflection for all of us, which has been the experience, particularly in first wave and certainly further in nursing homes, and the severe impact that we see in COVID and the pandemic take on lives in nursing homes for some of the most vulnerable elderly community. And that's something that personally struck me quite hard during the whole pandemic. And I think we all need to be honest and open and reflective about what is it we could have done differently, what is it that we need to do differently for the future. And certainly there's a couple of, a couple of reflections we certainly fed back to the expert panel and have been well documented, but there is a policy issue for the future. What is the strategy in terms of healthcare? Should it be defaulting to nursing home investment, public, private? Should we focus our investment in longer term care at home and in the community, and not just from a health system, from a public investment system, whether it's community systems, whether it's housing infrastructure? So I think there is a big lesson here around the preparedness of congregated settings, in particular nursing homes, to cope with a pandemic. The fifth kind of area of reflection, which I would put in there as well, is equally the new ways of working for us, not just in terms of community care, but in terms of how we had to embrace technology in a whole new way, in a different way. Outpatients clinics, something like Michael's presentations, delivering the outpatients clinic, not necessarily in the acute hospital settings. Virtual clinics, online clinics, physiotherapy clinics, mental health clinics, which were held online in a whole new way, virtual clinics. And that whole piece of integration, teams working from the acute hospital system in an integrated way in the community in terms of some of our nursing homes and elder care supports. So 5 quick, just broad reflections that I would put there looking back. Looking forward, I would say, like Michael and indeed Jessica, I look forward with great positivity for health systems about what we have learned from the impacts of COVID. And the first kind of area I would say that we have to look at differently is the whole issue around of a national health system and how we look at the health system delivery through a public health system, a voluntary health system, which we have very significantly in Ireland, and a private health system, which we have very significantly in Ireland. And I think we do need to embrace all. I think for too long our policy and our strategies got hung up on public versus private. And I think there's a role for both. And I think during this pandemic, and particularly in this wave of the pandemic, we have leveraged and worked with the private health system in a very new way to sustain non-COVID services during the pandemic. And I think as we look forward to things like waiting lists, we have to work with the private health system in a much more integrated way. So public and private, and so many of these issues are policy. I'm not trying to stray into the policy areas, but they are ways in which we can deliver health differently in the future. And the second area revolves around, again in Michael's presentation, but one I'm a strong advocate before I took this job up. Probably the primary reason I took up this job is that I do believe in a very big change agenda around healthcare delivery, strengthening community services. Now, that is not, I'm very conscious that the audience, particularly on Dublin, that is not at the cost of or to compromise the investment that's needed in our acute service, which I'll come to in a minute, because sometimes every time I say this, I can be challenged on that. But it is about working with our GPs in a whole new way. Throughout COVID, throughout our winter plan, giving our GPs access to diagnostics, bringing the GP and GP services and practice much more closely into the health family and health system. They are independent operators, but they are very much part of the health community. And I think this phase we have worked really strong with them, whether it's throughout healthcare and COVID response hubs we have in place, whether it's testing and tracing strategies, or now indeed in a very strong way in our vaccination program, but equally in providing those diagnostics for GPs. Step down care, how we can provide step down from the acute side into the community side in a new way. Home supports, many of the areas that we've seen the benefits from the first phase of COVID, or the first few phases of COVID. The third area I would set out very strongly for us is a big learning around a pandemic capacity or capability in Ireland. There's no doubt, like many health systems, we were not prepared for a pandemic to the extent of which we needed to be, and certainly need to be for the future. And if you look at a lot of what we built up over the past year, now 2,000 people involved in testing and tracing and swabbing, and indeed in public health. A whole new set of workforce built and designed, but it has to be a workforce in the future that we can scale up and scale down as required at a very quick and flexible and agile way. We can't have a fixed workforce that we don't need all of the time, but we need to be able to respond to pandemics. And just even use the example of our lab capacity. At the start of this pandemic, we had one fundamental big research lab capacity, which is the MBRL capacity. Now we've 47 lab capacities. We've probably 2 or 3 major infrastructure of lab capacity now to support us. And that's been a whole new way of building a pandemic capability and capacity for the future. That's certainly the third area. The fourth area I would say has to be around the acute services, and how do we tackle a very significant backlog and impact on waiting lists that we now have incurred throughout the pandemic. And that again revolves around looking at the health system, I believe, in a very integrated and coherent way. The role of public, the role of private, the role of GPs, the role of outpatients clinics in a very new way. I was in City West just last week with the Taoiseach, which is a campus, hotel campus that we worked with during the pandemic. And out there, it's quite impressive what you will see now, certainly from an acute and how we address on waiting lists. We have areas that we had originally intended as a kind of field hospital, now addressing many of our waiting lists in a very different way. And I do think there's a whole new way in which we can look at infrastructure like that to help us address it. But also there is a fund now from government around access to care, an access to care fund, which we are working very closely with Robert Watt, the Secretary General of Health, around how we utilise that fund in a very different way, rather than just grant funds to hospital, but how do we tackle in a very targeted way, in a very different way, our waiting lists, which has to be
minutes, Paul.
Yeah, sure, Audrey. And finally, one just on the look forward for me is around the EHealth and technology. Sometimes we have set this out in a very strategic way, which it needs to be, in a future direction. And I know Michael and his team have done some great work on EHealth and technology. But equally during COVID, we put solutions in place that helped pathways of care. So very briefly in COVID, respiratory illness, which it obviously is, a lot of our remote monitoring we were able to do for patients, not in hospital system, but discharge them very quickly and do remote respiratory care. But there's a lot more innovation which we need to embrace. So finally, Audrey, for me, I think there's a few very good reflections we need to make from the last year, and a few ways in which we really need to build them into our future ways of healthcare. But if I was to put one out in particular, I'd say operate at pace and operate at risk. Manage risk in healthcare. That's the pace. Thanks, Audrey.
Thank you, Paul. And you can stay for most of our Q&A. That's brilliant. Thank you very much. Paul is staying with us, David, Jessica. Unfortunately, Michael has had to leave us. He has a busy schedule this afternoon, so he couldn't stay for our Q&A. But you're sending in your questions, which is great to see. I'll get through as many of them as possible. And David, I'm going to come to you first. And just a reminder to our panelists, just to remember to switch on your mics and your video so we can see and hear you clearly. I was very interested, David, in when you talked about whether the positive changes that we witnessed during the pandemic would stay with us, and you thought that perhaps they wouldn't, that we would return to how we operated pre-COVID. Why is that, do you think?
Well, I think the underlying systems and structures and processes and incentives that operate within health systems typically haven't changed. People are typically reimbursed on the same basis. People's contracts are the same contracts they've typically always had. And the old system, worked for many of the individuals in it reasonably well. So I don't think it's inevitable, but I think it would be naive to assume that things are just going to change. I think it's more likely, people are tired. They've been working incredibly hard during the COVID crisis under a lot of stress. And I think it's more likely systems tend to snap back to the way they were after stress than sort of stay as they are. Now, that won't be true in everywhere, but I think it's the wrong assumption to assume that the things that we like about our COVID response and the way that are going to stay, and somehow the things that we don't like about it are going to be the ones that dissipate. So maybe I overstated the case, but I'd be more biased to take action and active action to keep the things that we like, because I'm not sure that they actually will stay.
And Jessica, one of our audience members, Stephanie Skeffington, picked up on a quote that you said, explore collaborations with people you have never considered in the past. And Stephanie says, this is a great recommendation, Jessica, in a time when our healthcare system has gone through such needed and long-awaited changes, and that this would further reinforce those changes and keep the momentum of changing things for the better going in our healthcare system. Do you agree?
Absolutely, 100%. I think what David just said illustrates that point. The path of least resistance is to snap back to the old ways, which includes working with the collaborators and partners that we are used to working with or that we view as safe or traditional, and forcing ourselves to challenge the assumptions that those are the right collaborators or that there aren't other collaborators out there is really a way to maybe not snap back quite so quickly, quite so easily. Now, I'm not going to be naive and say that the enormous amount of effort and resourcing and even money that needs to go into preserving the current COVID ways of working aren't important. But if you're looking for low cost, less onerous ways to try to maintain some of these lessons learned, that's a quick one. And I'm glad that Stephanie picked up on that.
As you might imagine, Paul, there's a few questions in for you from our audience. Let me just read this one from Colm Horan. Colm asks, how can we realistically claim to have learned anything valuable from the past year when the discipline of public health medicine, which should be at the center of both our pandemic response and our plans for health service reform, is described by those working in it as in crisis? That is a workforce we do need to be permanently bolstered, yet it is one that saw itself needing to resort to industrial action as recently as this January. Colm says he appreciates that the sticking point to sustained investment appears to be largely at government rather than HSE level, but he wonders if you could comment on the broader substantive issue to do with public health.
Yeah, Colm, thanks for that question, as they always say. A few things I would say on that. First of all, I don't think it would be right, and I'm not here to defend government, to say the issues are now with government. I have to take responsibility for what has to be resolved as well. We have secured a very significant investment, one of the biggest investments ever secured from government for public health, which is about resourcing a pandemic workforce plan. That plan is currently in recruitment phase at the minute, which is to double the capacity of the public health teams. I talk regularly to public health leads. I actually chaired a call last Tuesday with about 12 of the public health doctors all across the country where we spoke through much of this. And I think you can't just look at it in isolation from the public health teams. It is about the significant investment that's also gone in parallel in relation to the testing and tracing capacity and capability. That is all part of a single and integrated pandemic plan that we have to have in place, which are about new testing strategies, embracing new testing strategies, but resourcing the public health workforce to be able to act on that intelligence. So I think there is an investment there. It's a very significant investment. It is doubling the workforce. We doubled it temporarily, but we want to double it based on a permanent scaled recruited workforce. So I would be strongly of the view, I don't think there's any reaction from government that has to be invested, and I've got good support on it. It's taken longer than we would all like, but that investment is there, and I speak to the public health teams very regularly on it. So I share the frustration, but that's to be frank, I think it's a role for the HSE as well as government.
Paul, another question for you on today's story to do with vaccines, of course, and the AstraZeneca decision to restrict, or at least the NIAC's decision here to restrict the AstraZeneca vaccines to just the 60 to 69 year age group. Simon Carswell from the Irish Times is asking this question in relation to that and today's decision by Johnson & Johnson to suspend its vaccine rollout in Europe significantly. Will that disrupt our vaccination program here in light of the fact that if you combine AstraZeneca and Johnson & Johnson, that represents more than a third of the projected vaccine deliveries for these 3 months of April, May and June?
Yeah, and Audrey, obviously a lot is breaking in the last 24 hours between, we've been working late last night, we're working throughout today, and we're going to be working late tonight on revising the model, the operating model based on the decision yesterday from NIAC and recommendation yesterday from NIAC, which we fully endorse. And obviously what's breaking today in terms of Janssen, we'll have to wait now to see where the DMA assessed that. Just on the Janssen one very briefly, our volumes certainly for the next couple of weeks were relatively low from Janssen, but Simon's right, there's 605,000 of our 3.9 million for the quarter. And he's right too, that 21% of the AstraZeneca is our volume for them. So in summary terms, we're currently working through a model between today and tomorrow, which we'll bring the Minister and Government through, which sets out how we're going to reset the programme based on the foreseeable, based on the fundamental change from yesterday, and just stick with yesterday, is about who can get the AstraZeneca and how we realign our model, our operating model, because it was currently geared towards GPs addressing a lot of the AstraZeneca vaccine to some of the medically vulnerable. Now we have to look at that very differently again, and that's what we're working through again tonight. So in summary terms, we're going to recalibrate, reset the model for it. The Janssen one, I can't really comment on, it's literally just breaking. But in the same way, we will have to, you know, I said this at our press conference last week, we've had to change our operating model 23 times over a 15-week period, whether that was changes to vaccine types, changes to prioritization, changes to locations for vaccines, or changes in impacts on delivery, and we have to do this one again. So in summary terms, we're still working on it. We've another 24 hours or so, you know, to finalise an operating plan, but I will expect that we will be resetting rather than, you know, revamping the whole program, and it's about the channels of delivery, but the volumes, you know, obviously the Janssen one today is one. We'll see what happens next.
Paul, thank you very much. Jessica, just on that, I suppose, and your background is in you know, the multi-party vaccine development alliances. You worked with Pfizer as well. Do you think these problems that we are witnessing will have an impact on confidence in vaccination generally?
That's a great question, Audrey, and I would love to be able to say no, but unfortunately, I do think that there will be an impact. Not because of these vaccines specifically, let me be clear, but because there already is an underlying vaccine skepticism group of or mentality that permeates all parts of society right now, and this certainly doesn't help. I think the rapid response and the fact that these health agencies are taking these questions very seriously and are taking steps to limit the risk is certainly a step in the right direction. And I also believe strongly that the regulatory efforts that have been seen to date, and I can say this particularly in the US, but also in some of the European countries, have been seen to be strong and not compromising despite their speed. And so from that perspective, I think both of those have helped. As we see the variants take over and form a larger part of the infectious burden, I also expect that some of these concerns will start to be outweighed by the risk that some of these variants carry, particularly to the younger populations. Now that we're seeing that most of the hospitalized patients are under the age of 50, at least in the US, and I believe some of these numbers are mirrored in Europe, the calculus of that has fostered or allowed some of this anti-vax or vaccine hesitancy to move forward, I think will start to change, because the trade-offs will no longer be no vaccine and unlikely to be hospitalized to where the benefits could outweigh that risk.
Jessica, thank you so much indeed. David, can I bring you in and ask you about something that Michael Dowling raised in his presentation, where he talked about how he viewed the future of the acute hospital sector, that he believed it would be become essentially an ICU specific centre, highly specialised critical care. Do you envisage that? Is that the way the system is going in the future? Are we set up for that yet in this part of the world?
So I think most people would argue that that's the right direction of travel. The hospitals both should be there only for those things that require, genuinely acute and urgent treatment, that they're not good places for vulnerable, those who have health vulnerability to spend time, etc. So I think that is the clear direction of travel that most people would articulate is right for a health system. It's better for patients, and it's better. It's a better use of public money to invest in, non-acute care. I think that the puzzle there is that people have been saying that for 10 years probably. Progress though has been slow, and I think what we do know is that it's quite hard to make the changes to the health system to move it forward. So for me, it's less a question of the direction of travel, which I think most people would recognize and support, and much more about how do we get there, and which in some ways is one of the reasons I think we should take some hope or some optimism from the COVID crisis, because what I think it has shown is that health systems are capable of change, enormously rapid change in some cases, and change more rapidly than I think we've seen in almost any other sector, in the past 15 years. So I think that both the health systems are capable of change. I think we know where we want to go, or most health systems know where they want to go. I think the trick is actually, can we organize to get there at a speed that is appropriate and serves patients' needs. And I'm sure it's something Paul, when he's not thinking about COVID, spends quite a lot of time thinking about.
Well, funny enough, I'm going to bring Paul in because there's a few questions for you, Paul, related to this. Francis Dockery says, I am a geriatrician working half time in community and half in an acute hospital. I'm delighted about the planned investment to enable us to keep older people away from acute hospitals in the much safer environment of their own homes. But I echo a previous comment on huge IT investment needed alongside. I see huge duplication, she says, in paperwork and manpower needed on said paperwork from both sides, much wasted time, no ability to measure KPIs, etc., etc. And that previous comment that Frances mentioned, she talks, this was from Camilla Carroll, who says significant change has taken place throughout the health service over the past year, but we are significantly handicapped by the lack of an electronic patient record and digital technology. And this impacts on the ability to deliver safe and effective integrated care, which is the foundation of Sláinte Care and which is at the heart of what Michael Dowling was talking about earlier. Would you address that, Paul, please?
Yeah, again, a great and loaded question here. And I fully understand the frustrations that people work within healthcare and the legacy issues that we have. And it's, I have to say, it's been a cause of, it's been a major learning for me. And I can understand the frustration if this is the way it has been for so long. I think one of the issues, again, just reflected on COVID, where I think we need to do, so for example, on electronic patient records and individual health identifiers overall, there's a lot that has happened in the last while that we need to build on and consolidate. So for example, in our vaccination program, as we're rolling that out, and our testing and tracing capacity as we were rolling it out, building that information so that we can have that single health identifier and we have the information that we need to capture it as we're going along. So we're making good progress on the vaccination program to help us along that journey. The other piece I would say is that to help people's frustrations, I think we should not always wait for the big end game strategic across the whole health system solution, which many of which you just described and we want to get there to do. But certainly what I've learned in the past year or so is using a lot of the information and data that we have in a very different way to inform us can be really strong. So we've created things like data lakes now. So the information that comes from public health, from testing and tracing, from our vaccination program, being able to give us real intelligence about what's happening in healthcare, and when you clash some of this data to inform our decisions and better in the future. So I think there's a bit about utilizing the data that we have, building simpler technology and integration solutions, to bring us on that pathway, because my kind of learning was we're waiting for the one big end game solution, whereas we should be building the opportunities along the way to get us there. So, and I do think we're starting to do that in a different way, but I fully appreciate the frustrations people have.
Yeah. Well, thank you very much, Jessica. I'm just going to come back to you because I know you're going to have to leave us very soon in the next couple of minutes. I just wanted to get your views on achieving health equity, health equality within a private healthcare system and a public healthcare system like we have in Ireland, like there is in the United States, obviously, of course. How can you achieve health equality when within private healthcare?
That's a great question, Audrey. And we actually have been grappling with that very question ourselves at the foundation. And we've arrived at the conclusion that you need to address it both from a supply and a demand side. You have to have the resources and the commitment to equity. In other words, having the right infrastructure in place to ensure that everyone has access to care. But you also have to arrive at it from the supply side, ensuring that the very users who often get left behind know that they have options and are convinced to make the best use of those options. And as you can probably imagine, issues of health equity in a high income country like the US or like Ireland are different. Those are more a question of choice. As well as a question of resources versus health equity from a global health versus global south versus global north perspective, which is more around resourcing. So speaking about a private healthcare system, that supply side cannot be understated. But the demand side is equally important. And what we have found is that empowering patients to know that they have those resources and that they should want to seek them out by either addressing historical concerns over trust, by ensuring that there are faces that match theirs when they walk into a hospital, by ensuring that they see themselves as part of the clinical trial participants and the populations that help to bring medicines and vaccines to them and to the broader public, and by ensuring that we know we don't backpedal or fall back. There's been a lot of effort to ensure that vaccine hesitancy and treatment seeking is bolstered, or rather vaccine hesitancy is addressed and treatment seeking is bolstered with COVID, but we also want to make sure that we don't backslide once COVID and the urgency of this goes away. And so that's, I guess for a high income private as well as public setting, I would actually say that both sides of the equation have to be addressed with equal sense of urgency and resourcing.
Jessica, thank you so much. We let you go now at this point, but great to see you, and thank you for joining us at our conference today here in Dublin. Jessica Martinez leaving us now. We are still joined for the next 7 or 8 minutes by Paul Reid and David Meredith. And David, just picking up on that with you in terms of leveraging any relationships between the public and private sector to enable the public sector perhaps to bring about lasting reforms, lasting transformations at perhaps a greater speed?
Yeah, I think we always have to be a bit careful about sort of assuming that the private sector has all of the answers, particularly in a system of socialized medicine, because it's very easy to cherry pick examples of good and effective management and performance from the private sector. And there are plenty of examples of things that don't work well in the private sector. And we're all kind of exposed to, poor customer service or, failures of ethics or other things. So I think the first thing is, I think it's quite important to be thoughtful about how and where the private sector can help, and not take an ideological approach that says, yeah, the private sector either knows better or the private sector doesn't know what it's doing, but actually be really thoughtful about what the private sector can really help it and where it can provide that help, and actually where, for reasons of incentives or access or otherwise, the private sector isn't a good partner. I'm not someone that believes the private sector is great and the public sector is rubbish, or vice versa. So I think the first thing is just to be really thoughtful about where the private sector can help. But I think with that mindset, of course, some of the great successes of COVID have been about effective partnership, particularly with the pharmaceutical sector and the rapid development of vaccines, but which was largely funded by public sector money. So we know it can work, and there are good examples within healthcare of good collaborations with the private sector, but there are also plenty of examples of where it hasn't worked well. So PFIs, for people would call it in the UK, which were the private finance initiatives where the private sector built hospitals, ended up being really quite expensive. I think the analysis that the Treasury done in the UK suggested that wasn't. So I think it's the important thing is, I think, to be really thoughtful about where the private sector can help, and to engage with the private sector in a way that plays to the private sector's strengths, but ensuring that you understand the nature of the contracts and the relationships you're entering with the private sector. So actually it does deliver the value for money outcomes that you are trying to reach. And that does require some thought. And I think it's not always the case that the skills exist within the public sector to contract effectively with the private sector. And equally, I'm not sure it's always true that the private sector necessarily has the right sort of mindset and skills to contract with the public sector. So I think I would always counsel sort of caution and thoughtfulness about that. I think it's all too easy just to actually the private sector with all the answers, let's go. I don't think that is the case.
David, thank you very much. Paul, another question here from one of our audience, from Bridget Cunningham. She would like you to comment, please, on the earlier insight. This was a discussion that we had earlier on in the afternoon, that to truly tackle waiting lists, scheduled care needs to be separated from acute care, which may mean streamlining or even closing some smaller local hospitals. I can't see the political will to do this due to our traditional parish pump politics, but would be really interested to hear the HSE's perspective on this.
Yeah, thanks, Audrey. I think if you look at it from government policy perspective right now, just to say what that is, and that is set out in Sláinte Care, where we build elective capacity and dedicated elective hospitals, and that's that's the policy direction, if you like. My own sense of it is we don't really have the luxury of a lot of time to get to that position, and we have to find a pathway along the way to address our waiting lists. There's no doubt that strategically you look at the configuration of hospitals in Ireland, you certainly would not design them in the manner of which we have 19 emergency departments across the country dealing with the challenges that they have in terms of resourcing and capacity and capability. The trauma strategy, just to say briefly, does give strategically policy, I guess policy, people who develop policy in government choices, because the trauma strategy sets out a whole new way of delivering trauma in Ireland, with a couple of main spokes and hubs of it. And that is an opportunity strategically to look at the configuration of other hospitals that, you know, during that journey. Because if you create a dedicated trauma centre in decided locations, it does give you an opportunity to say, what can you, if you take trauma out of some hospitals, what can they be then reconfigured to do differently? So strategically, I think that's an opportunity. More immediately, I guess in the short term, I do think we need to do some of what I've just said. I mean, the innovation I'm seeing in City West, and it's not that City West is our long-term solution, but the process of trying to address a dedicated waiting list out of an acute busy hospital has to be a line of flight that we go on. And I've seen children's waiting lists for certain treatments wiped out in City West, out of not happening in the CHI hospitals, but out there in City West. And again, when I visited last week, it was quite impressive. We have a couple of key well-known surgeons out there last week, plastic surgeons out there last week, just seeing what's possible from their perspective as well. So I think there is a way about looking at it differently. There is a way of outpatients. Not all of our waiting lists, by the way, are acute waiting lists. Many of them are community waiting lists. So I think strategically, trauma care and configuration of hospitals, right direction. But you know, your commentator is right. This is not politically easy. So I think we need to make some steps along the way to help us. And I think the funding in the National Service Plan for this year, which is 240 million of an Access to Care Fund, does give an opportunity for us to start making an impression.
Look, we're grateful to you both for your time this afternoon. Thank you very much indeed, Paul Reid and David Meredith. Well, that is almost us for today. Thank you for joining us and for taking part, for asking questions, giving us lots of food for thought and challenges for everyone involved to make the changes that you all believe is necessary for our healthcare system to deliver that healthcare for all of our people. So before we sign off here at the Royal College of Surgeons, a final word now from the Managing Director of Healthcare Management at the RCSI, Eunan Friel.
Thank you, Audrey, indeed, and thank all our speakers. Just a housekeeping matter, lest I forget, just to say that the session has been recorded, and pending speaker agreement, all the sessions will be posted in the next week or so, including the Minister Donnelly's video at the start, which unfortunately was interrupted by some technical issues. So just to get that out of the way. Again, I'm not going to attempt to sort of summarize, but I guess I was struck by the remarkable convergence and agreement around what good looks like as we go forward. And as ever in healthcare, it becomes the challenge of execution. A number of takeaways from me. One certainly around the opportunity arising from the centrality of healthcare to the sort of global conversation as being key to societies and economies, and how we not lose that opportunity that healthcare has occupied the center of the global stage. I guess we're all struck too by the coexistence of great crisis and yet great opportunity within the system. We've seen new ways of working, we've seen new ways of managing patient flow, new ways of spending our resources, and a reminder of the centricity of sort of patient outcomes in the middle of all the often politic and bickering of healthcare policy. There was an interesting conversation about not losing the opportunities when sort of years of innovation happen in weeks, and that's certainly what we've seen. Sarah talked a bit about the opportunity when you get a convergence of a problem of politics and of policies, and I might add a fourth P, and that is of public. And I think we have that convergence now, and we need to grasp it. The issue of policy entrepreneurs, and those entrepreneurs being very much in the front line, and how do we not lose those myriad of small innovations. I'm often struck by the acceptance that all problems in healthcare are intractable, and all problems in healthcare have to be accompanied by tens of millions of euros. We've seen that's not all the case, and we have to, I think, be very careful not to lose those myriad of innovations driven by real people solving real problems, sometimes small problems, sometimes not so small problems. The big theme of health system integration was brought to life, I think, dramatically by Michael Dowling's presentation. I think the data point that's stuck in my head is that of 15% of his budget spent on the acute hospital sector. So it gives us a sense of how far we have to go. I stand to be corrected, but I know the corresponding figure here is more than double that. So that whole health system integration is really, really key. I guess, also Jessica's comments reminding us of the issue of health equality, and it not just being a moral issue, but a public and global health issue for the North, the global North, as she referred to us. And I was finally encouraged by Paul's tolerance to take measured risk in healthcare and to recontract with the public built on trust rather than criticism of our health system, which I think has been destructive in the past, and that's a real opportunity for us. And his commentary, not all about integration of acute and primary, but also public and private. Really, really good. So I guess I'm standing between you and a cup of coffee. In closing, again, I want to sincerely thank all our speakers for their energetic presentations and their demonstrable sort of passion in their subject areas. I do want to call out a special word of thanks to RCSI's own communications team and our events team, specifically Claire Phelan and Paula Curtin, who did phenomenal work leading up to this event. On all of your behalf, I want to thank our chair, Audrey Carville, for, as ever, her clarity, energy, and keeping us all to time this afternoon. So thank you very, very much, Audrey, for that. And lastly, to thank our audience for hanging with us. It's a long afternoon listening to lots of slides and presentations, but thank you again for your interest. I think it behoves us all who have the opportunity and the responsibility to influence the future direction of care. And I think particularly as we approach, a horrible global milestone of almost 3 million deaths from this pandemic, to take the learnings and the opportunities that we've seen today and to maximize their integration into how we plan going forward. So again, thank you all very much for a very productive afternoon. And I hope this time next year we will be able to welcome you in presence to St. Stephen's Green. So thank you all again, and have a great evening. Thank you.